Here we present an endoscopic resection of a congenital cholesteatoma. The patient is a young boy with no otologic history of otitis media or myringotomy tubes. The pediatrician and subsequently a referring otolaryngologist noted a left anterosuperior pearly white middle ear lesion. The child had a normal audiogram. The CT scan showed a well-defined lesion just anterior to the malleus handle. The hearing was normal. This is an intraoperative view of the same child. The relevant anatomy is labeled. Local anesthetic is injected into the vascular strip very slowly and a traveling wave of blanching skin can be seen. Next, an angled beaver blade is used to make a standard 12-6 incision. A suction elevator is used to raise the tympanomeatal flap skin to the level of the bony annulus. The flap is kept on a broad plane. Once we get to the bony annulus, we switch to a suction Rosen elevator and perforate the middle ear mucosa. Next, we use a 20-gauge suction and a small blade to lyse and raise the middle ear mucosa superiorly. Some of our anatomy is shown here. A blade is used to lyse the soft tissue attachment of the tympanic membrane to the malleus handle. The blade and suction are then used to raise the flap off the malleus. Once on the other side of the malleus, a glimpse of the cholesteatoma can be seen. A Rosen and blade are used to raise much of the flap off the malleus. A Bellucci scissor is used to cut the drum off the umbo. The flap is then reflected down to ensure no perforations are present. The cholesteatoma is exposed and the rest of the TM elevated off the lateral process of the malleus. Some more of the relevant anatomy is shown here. A right angle dissector is used to lyse the attachments between the cholesteatoma and the malleus and tensor tendon. This is done as atraumatically as possible. Angle dissectors are then used to roll the cholesteatoma out and block, and it is finally removed with an alligator. The anatomy of the middle ear is shown here with a clear view of the eustachian tube and tensor canal. The cholesteatoma has been completely excised. The tympanomeatal flap is then brought back down. There is some redundancy in it from the prior lesion. The ear canal is then filled with gel foam and bacitracin ointment. The postoperative audiogram was normal at 3 months.